Today, our discussion will be about non-specific low back pain as it pertains to the entire population, general population, as well as athletes. And that low back pain is referred to as a painful condition that affects the low portion of the spine or the lumbar region of the spine, starting from L1 to L5, as you can see on the picture, the highlighted portion to the right. L1 through L5. It also can affect S1, um, and you'll hear people complaining about sitting too long or standing too long, and it could be because of S1 is being affected as well. It affects about 85% of the population, both general population as well as athletes. Oftentimes you'll hear it referred to as lumbago, and about 3 million cases of lumbago are reported per year, raking in about $100 billion in treatment. And with that, even with the most high-tech and the most up-to-date testing and diagnostic tools and imaging, it's hard to pinpoint the culprit of low back pain. A lot of times you'll hear patients report it as knee pain or hip pain, and it's pretty much referral pain, not knowing that it's actually stemming from the back. And the progression of low back pain comes in stages, starting with an acute stage, which is ranging from the date of onset up to 7 weeks. Anything more than that would take you to the subacute stage, lasting from 7 weeks to 12 weeks. And then these two cases is where you would mainly see workers' compensation patients, people who have a traumatic injury, and or patients who feel that they may have they just continuously have this pain over a certain amount of time, and they decide to get it checked out immediately. But oftentimes with workers' compensation, we'll realize that the end goal is to get them back to work. So depending on their lifestyle, these things happen, and anything longer than 12 weeks would be chronic pain. So an episode of pain that's lasting longer than 12 weeks would be chronic, which you see a lot of in the clinical setting. And the reason being is that people will think, as well as physicians too, not just patients, that the pain will subside on its own, because we know that a good amount of patients who experience, or just people in general who experience low back pain, will get better. To be more specific, it's about 90% who are relieved from their back pain, and that they don't report it until later, and by that time the 12 weeks have passed. And some of the signs and symptoms of low back pain are is the pain itself. You don't oftentimes know until you know. And then it'll start off as stiffness, or a burning sensation, or a sharp pain, which could be a muscle spasm that's just lasting a little bit longer than it should. And patients will try to relieve themselves by doing different activities, such as trunk extension and trunk flexion, moving, sitting differently, just to relieve themselves of that pain temporarily. And then you have to consider other things once you feel that pain, or how long has this pain been going on? Was it just today? Has it been going on for a while? And we just thought, oh, it would go away, it'll subside. What caused it? Was there a traumatic event? What does your life consist of? What are you doing on a day-to-day basis that could have contributed to this? Are you lifting heavy objects? Are you in a pretty strenuous environment on a day-to-day basis where you're lifting heavy things, or you're bending over constantly? Are you a parent? Do you work with kids, or do you have little kids yourself that you're always running after and you're having to tend to? And are they your motivation? Would you like to get back to your lifestyle? Oftentimes that's the goal, just to get back to day-to-day living without the pain. As I mentioned before, 90% of people who experience low back pain tend to get better, but are you at risk of repeating therapy due to your pain? Just because 90% of the people get better, 50% of those people have a recurring event and then they're right back where they started. And some treatment prescription, which kind of piggybacks off of the previous slide, is, as I mentioned before, we tend to try to relieve ourselves of the pain by moving in a different way, sitting in a different way than we have before, that may have or could have contributed to the pain that we feel. Part of that is the McKenzie method, who Dr. McKenzie is a physician or a clinician who realized that, wow, when patients flex or when they extend their trunk, they relieve themselves of this pain. So we can come up with this string of movements to help alleviate the pain. However, it is a temporary fix. It isn't a gold standard. It isn't something to just take and run with, but it could help a patient. Low back pain or any condition is case by case. No two people are the same, so their back pain isn't going to be the same. The cause of it isn't going to be the same, so the treatment, it may not be the same. Stretching, which is also part of the McKenzie method, cardio and strengthening, we realize that with strengthening your core, you help prevent a possible reoccurrence of injury or low back pain. In that case, cardio. A lot of times we realize that people with a heavier mid area experience low back pain at a higher rate than those who do not. But with that comes strengthening your muscles. We hear time and time again, and we know, and we've seen statistics that exercise is medicine. Movement in itself is medicine. And speaking of medicine, we'll talk about the medicinal treatments. The local injections, steroid injections, which are corticosteroid injections to help inflammation. So it's an anti-inflammatory injection placed in the back, and it usually isn't suggested or recommended until other management, pain management mechanisms have been tried. We also will see a TENS unit, where electrodes are placed on the back and they send an electric current to the area or the surface where the pain is stemming from. And oftentimes it's paired with heat or ice to help move the stimulation throughout that area. We also have lumbar supports, where there's a pillow placed on the lumbar portion of the spine to help how you sit, which leads us to behavioral therapy. So postural adaptations, how you're sitting, how you're sleeping, are you rolling over correctly, and are you sleeping properly? And the reason I say properly that way is because no one's taught how to sleep. It's just something that you do. It's human nature. How you sleep is however you're comfortable doing. Muscle relaxants, a lot of people take Aleve or Advil or naproxen to help alleviate that pain, and oftentimes they'll become dependent on those medications. And we do soft tissue mobilization, where we're pretty much massaging the back, but at the same time moving the spine. And now it'll be a PA approach, which is a postural anterior approach, where you're pushing the spine from the back towards the belly, which is anterior, the knee. And what we've noticed from doing the PA approach is that patients tend to get a little bit more relief from it. However, without the exercise part of it, if you're just going by the medicinal things, you become more dependent on it. So it isn't golden rule. It isn't, it isn't something to just go off of. And as I mentioned before, exercise is medicine, and that's the best way to manage low back pain. Oftentimes, physicians won't prescribe physical therapy for the first couple of weeks because they feel it could just subside. But once physical therapy is prescribed, and we work on strengthening back muscles, strengthening the core, and stretching, which I mentioned before, strengthening the core itself helps take a lot of the pressure off of other parts of the body when you're trying to overcompensate. Postural adaptations I mentioned before as well, sitting upright, how you roll over when you're sleeping, how do you sleep. Epidural injections, as I mentioned before, aren't recommended until the failure of these other management initiatives that I mentioned above. And in this case study, we have a 44-year-old woman with global spine, low back pain, and bilateral hip pelvis pain. And what's interesting about her is that her mother was diagnosed with osteoarthritis in her lumbar spine, at the same time she was in her early 30s. And because of her pain, she's had to stop working. Her mother did, pass away early, and she's afraid that the same thing will happen to her. She leads a more sedentary lifestyle now because she isn't working, and the pain level is just so high that she really can't do anything. So her age is a risk factor, as well as her activity level and family history, leading her to be at high risk for low back pain. And ultimately, the goal of physical therapy for her or pain management is just to be pain free and get back to her life prior to her pain. And she didn't have a traumatic experience or a traumatic event that led to the pain. It just started out of nowhere, and arthritis is part of the reason. And some special considerations is that she does take pain relaxants, so we do recommend that she takes them 30 to 60 minutes prior to coming to therapy for her treatment. Health history, tolerance level. Is she able to do the cardio? Is she able to walk? Is she able to get on the bike? Is she able to stretch? Is she able to move? And that's part of the reason we have her take the medication before she comes, so that she can do all of these things without her pain level going higher than a 6 on a 0 to 10 scale. 10 meaning I need to be in the emergency room, 0 meaning I don't have any pain at all. Some exercise testing that we would do would be strength test, which it includes but isn't limited to abduction with resistance, adduction with resistance, hip flexion and hip extension. As you can see on this image here, when you flex your hip, you should be able to lift it about 90 degrees while you're laying on your back. And when you're laying on your stomach, you should be able to extend your hip at least 15 to 20 degrees. And then we also do flexibility tests where we're stretching the quads, we're stretching the hamstring, and textbooks say that when doing a quad stretch, the heel of your foot should be able to touch your gluteus maximus. Trunk extension, trunk flexion, which we mentioned before, is part of just to see, can you do it? Are you able to do it? Observing the patient's gait, how they walk, are they overcompensating with their legs, trying to, relieve their back of pain. And after we do the testing, then we lead on to the exercise prescription, which most times it's talked about between the clinician and the physician, where they will have a patient come in for 2 to 3 times per week, and we work on strengthening, we work on stretching, we work on cardio, whether it's the bike or the treadmill. For stretching, the 3-way ball rollout, and you're holding it out there for so long, as well as trunk rotation and leg raises. And with that said, it leads us to our conclusion, where exercise is medicine and lifestyle adaptations help relieve pain from the lower back.